This morning we're going to hear from Dr. Stewart, our chairman, and as a brief background, Dr. Stewart's originally from Odessa, went to medical school here at the Health Science Center, did his residency here, did his trauma critical care fellowship in Memphis, which is where I met him, and for those of you looking for some inspiration, I can tell you he inspired me before I ever met him. When I was a second-year resident on the trauma service in August of my second year, I heard the ER nurses and OR nurses talking about the new fellow that had just come in. And I'd never met the guy. And they said, you know, we used to always say you want Dr. Fabian on call when you get injured in this trauma center, but now I'm convinced that if that new fellow Stewart's around, it doesn't matter who the faculty is. And I thought, that's something to aspire to as a resident, if you can make your faculty obsolete. And so I used that as personal inspiration for the rest of my residency. I would encourage all of you to do the same. Since that time, he's gone on to do great things in the residency and in the department. He's the recorder for the Southwestern Surgical Congress, which means he's the editor for the American Journal of Surgery for part of the year. He's the secretary of the Texas Surgical. He's been our interim chair and subsequently permanent chair now for several years. And also as a resident, was the only person ever to win the Southwestern Surgical's Resident Research Award twice. So he's accomplished great things in his short career, and we welcome him to the podium this morning. Dr. Stewart.
Well, that was way too generous of an introduction. And the good news for the residents, it's easier to make me obsolete today than it was in 1993. So you have an easier task. Let's go. Okay, so I'm going to talk about malpractice for the surgeon. I'm going to basically give an overview of what I think are the risk factors for malpractice, try to talk about things that each of us can do to reduce your malpractice risk. And then I'm going to talk about what the impact of tort reform has been in Texas. So kind of two phases: risk of malpractice, how to minimize risk, and then talk about what are the policy reforms in Texas. Well, you know these folks. We see them. It's Mary Nell. Just call me. It's her little tagline. They always in, just call me. So there is a malpractice premium crisis in many areas of the United States, with high-risk policies for malpractice coverage over $100,000 in some areas. And this tends to drive doctors away from high-risk practice areas. There's an emotional component from the attorneys and from the physicians in that it even drives people away, even if the risk is not as high. There's a perception of increased risk, sort of the adult version of the mean world syndrome for kids. If they watch too much TV, they get the perception the world is worse than what it is. So in 2003, though, Texas passed comprehensive tort reform, and they really passed, wasn't really talked about, but they passed comprehensive reform of the TMB, of the Texas Medical Board as well. Both those have ramifications for us. This just shows the increasing claim rates in the United States. The data is a bit outdated, but no question that in many areas of the country, those claim payments have reached a crisis point. And as I said, I'm going to basically talk about I'm going to try to answer some questions, what are the malpractice risks, and then talk about tort reform. So who does sue? There's many myths about many myths about malpractice. And I think that happens when there's an emotional, when there's a lot of emotional context to it. And malpractice suits really do affect emotionally physicians negatively. There's a recent paper by Charlie Balch talking about that. But who does sue? Well, the entitled and the angry. That's who really sues. You often hear the trauma patients are more likely to sue, but really the data don't support that. If you have an affluent patient with commercial, or probably I would guess the highest risk for the plastic surgeons of the audience, probably the highest risk is the patient paying cash up front to have a cosmetic procedure is probably higher risk than these patients. It wasn't in this study. And the angry, I will just point out, and I think the data support it, it takes either a lot of resources or an anger that's held over that can be sustained over a long period of time to bring a lawsuit to fruition, usually. It takes someone who's committed to do it, except in the rare case of the dramatic situations when probably the patients are really more courted by the plaintiff's attorneys, but the entitled and the angry. So why do individuals sue? This has been looked at in numerous papers. Communication is usually in the top three. So there's usually a breakdown in communication, oftentimes a total failure in communication, a negative interpersonal interaction, a fight with the doctor, or ultimately a complete collapse of communication. Physician attitudes, people have looked at this and just they've done voice analysis of tone of voice, and they can predict who's been sued most often based on their tone of voice and communication with the patient. So the attitude, particularly arrogance, is and a condescending approach generates anger, and if there's problems, then a lawsuit's more likely. Other things, financial gain. You'll see from the tort reform data that limiting financial gains and adding rules makes it where the lawsuits are really fall off. So financial gain is part of that. Physician disparagement of previous care is a common preceding factor. And I'll just say, if you've sat in as many morning reports as I have, it's very common that when someone hasn't taken care of the patient, they're more negative when they present it than the people who took care of it. So I think we should be very careful about being negative about previous care, particularly most of the times when the person who's taking care of the patient, we don't know, or they don't know what actually even happened. So try to take the see no evil, hear no evil approach with respect to that. Media attention given to a problem. When that happens, you'll see a rash of lawsuits. And advertising, of course, they advertise for all that. And unrealistic patient expectations. Again, looking at why individual patients sued from Hickson and JAMA in 1992. The patients, when described, they felt devalued, deserted, a lack of understanding, and they felt that there was poor communication. Those are the reasons why the patients give. Devalued, left alone, lack of understanding. Linda Crawford, participating in a debate in Archives, summarized her view that she said it's not usually about bad medicine, 20% of the time it is. She made the point a little counter to what I've said. It's not about bad relationships, it's about unmet expectations. That if the patient expects something to happen, and it doesn't happen, they're unhappy. There's an architect, I had the privilege of participating some in the design process of the new hospital, and there was an architect who said, I'll paraphrase him, who said, the chasm between what's expected in reality is filled with anger, hate, and animosity. That gap is a big problem. So managing expectations is particularly important. This is a challenge for us because expectations are high, and we don't go out of our way to discourage the view of us as miracle workers, and popular media sort of looks for that. So you have to be careful about what expectations are. And almost 40% in her data were in healthcare or had a family in healthcare. So trying to summarize all this, looking at a typical picture of someone who brings a lawsuit, they tend to be unhappy or angry. They tend to have had a negative interpersonal interaction with their physician or team or providers. Their expectations were unmet. They have either a need or desire for financial gain. So when you have a big injury, like an anoxic brain injury or something like that, the patient has there's not only a desire but a need for financial gain. And if they've talked a lot with healthcare workers, or they have a healthcare worker in the family, or a physician who's taking care of them was disparaging about the care, those are high-risk patients there for. So a couple of questions. That's our data. We looked at the question of you hear this, it's common that people say, well, I don't cover the emergency department because the emergency patient's more likely to sue. It's inconvenient. And so we looked at our data. We're fortunate from Carrie Page that we have the operative database that at least gives us a denominator. A lot of times you can't get everything you would like out of it, but you get a pretty good denominator out of all those forms that we filled out over 4 decades. So the incidence of lawsuit in elective patients, and these were these were general surgery patients, so not the surgical specialty. So by general surgery, I mean the elective and laparoscopic, surgical oncology, and trauma. And I think for this study, transplant was in there too. But there were 3 suits per 100,000 operations per year for elective. For urgent, there were 2.3, and for trauma, there were 3.1. So really, no difference with respect to a lawsuit. No difference with respect to relative risk. All of those cross 1 by patient group. And then if you looked at cost, there's no significant difference in cost. The elective group made up $3.76 million, but had by far the largest number of patients. Urgent was $690,000, trauma $1.4 million. No significant difference between groups. But to be fair, the trauma lawsuits were 10% of the total, but 24% of the cost. Now, all of that 24%, almost 98% of that came from one patient, but it emphasizes the point that the risk of being sued may be one thing, but if you're taking care of a sick, high-risk subset of patients, the risk is maybe greater from a financial point of view. So therefore, neurosurgery, obstetrics, trauma, cardiovascular, transplant have patients who, when they have problems, have a big injury. And indeed, looking at that, we looked at a subset of that. And if you look at not what correlates with suit, but what correlates with settlement, if you look at it settling with the patient, and no cases were lost, but you could say either losing or settlement. If you look at the patients who have death or disability, 8 out of 10 had settled in favor of the plaintiff or was voluntarily settled. If you look at those who have no death or disability, it's exactly opposite. So when there's a lawsuit brought, major disability or death correlates with payment, just from a practical point of view. But that trauma malpractice instance was purely on operative cases. If you actually considered the total, we had to estimate this because we don't have clinic volume for, or at least we didn't have clinic volume at the time for all those years. But probably a better estimate was 0.34 suits per 100,000 versus the 2 suits. So in summary, there was no, at least in our practice, there's no difference between elective care, urgent care, or trauma care, and the payment really correlated to disability and death. Now, to me, this makes sense. That there's definitely people in the country who don't agree with this. I know they don't. They've told me, but it actually makes sense to me because there's no when trouble happens, when complications happen, when injury happens, if it's elective, there's a whole set of dynamic that makes the patient maybe even more unhappy than what they were if they were a trauma patient. They were actually walking around and were doing fine, and then it's totally, there's more people to blame. So I don't, it makes sense to me. Studdard and Mello, Brennan, have written more about malpractice in the United States than anyone else. And in 2004, sort of at the start of the patient safety movement, they point out here that the goals of the patient safety movement and the tort system are in conflict with each other. The patient safety movement says we need to be transparent and open. We need to basically identify our complications and have system solutions to that. The tort system says exactly the opposite. They basically say the things that for the people in the tort system is if you're transparent and open, you just expose yourself to greater risk. And they don't want to make it about the system. They want to make it about every individual because that's the way things get paid. So there is some conflict. So, and this is probably the weakest of our data, but we tried to look at whether patients presented openly at what was an openly attended M&M conference. It was Trauma M&M over a long period of time. Whether there were tattletale lawsuits from that. But I think more an interesting sidelight of that is it gives a good picture of what comes to a lawsuit. So there were 20,000 patients in the subset. There were about 6,000 complications. These were all trauma and emergency surgery patients. There were 6,000 patients in the ICU, and you can see the majority of the complications in that subset are patients in the ICU. So there are 4,000 patients in the ICU. There were about 860 deaths. All the deaths were counted as a complication. There were 412 patients presented to M&M over the time period. And there was that little red dot is actually magnified because it has to be magnified just to show up. There were 7 lawsuits over that time period. So 7 out of 20,000 patients, very small number. And you have to think about it. You have to think about of the 6,000 patients who had a complication, 7 filed a lawsuit. Very, very low risk. So when you looked at that, the M&M patients did have a not statistically significant, but a trend towards a higher malpractice lawsuit risk. But when you compared them to patients who had complications, there was no difference. And we could not find any evidence of tattletale lawsuits. As a matter of fact, all the lawsuits, the complications had been fully discussed with the patient. So it was, with the exception of a few who we actually didn't know, who were just seen in the ER and sued. So is there reluctance to sue? I personally think there is. As I've said, there are 7 suits for those 20,000 patients. And And then we looked at the special sort of trauma subset of patients that we called preventable deaths. There were only 2 suits in those 10 deaths that where it was a clearly deemed preventable, and 2 lawsuits. So in Texas, the landscape prior to tort reform is not the frequency of the suits to me. I really don't think the vast majority of patients want to sue, and the vast majority of patients do not sue. They don't. Most people do not sue. The problem is the magnitude of the settlements. So for example, 3 lawsuits in this last paper were $2.1 million. That's 2 years of collection. That was 2 years of collections at the time. So it's not that everyone's wanting to sue. It's the magnitude of the settlement. It's a bit like a lottery system in a way. The way the classic tort system works, most people don't sue. Most people don't bring lawsuits. But when you do, the attorneys hit the jackpot. Because that's also well known that the majority of that $2.1 million doesn't go to the plaintiff. It goes to other people, mainly their attorneys. So how to reduce our malpractice risk? Well, I think it's important to understand that average patient doesn't want to sue their doctor. Why is it important for us to understand that? Because if you take on an adversarial role, which is exactly what the plaintiff's attorneys want, they want you to be viewed negatively. That's what they want. Then they're very smart people. And the easiest way to take on that adversarial role is to just think that everyone's out to get me and sue me. Well, once you start thinking that, then instead of having a neighborly, friendly, professional relationship with your patient, you have a arm's length distance sort of. So the average person does not want to sue their doctor. Then you need to minimize negative interpersonal interaction. That really means, to me, just good doctoring. Being empathetic, kind, supportive, honest when there's complications. It's in most neighborhoods, not all, but in most neighborhoods, neighbors who know each other and who are friends don't sue each other when there's a problem that happens, if they have communication, if they're open and honest about what happened. So minimize negative interpersonal interaction. I would add one little caveat to that. I personally think that we need to focus on our quality and competence, because without that, this is a bit fraudulent to just say you just need to be nice to the patient. But clearly being nice and collegial with the patient is, or professional with the patient makes a difference. And manage expectations from the beginning. For everyone experienced in the room, you usually can estimate what the risk of problems based on the situation, and it's very important to accurately, not pessimistically, but accurately manage expectations from the beginning of the situation. I'll just say, whenever I have a severely injured multiple trauma patient who whenever I look at them, I don't know, but I can, based on probability, say it's going to be a month stay in the ICU, probably going to get a tracheostomy, may need a feeding tube, may not live. If I take 30 minutes or 45 minutes and have that conversation on day 1 and present that in what's the probable course, and it saves hours of conversation, and it tries to narrow that gap of expectations that tends to be filled with anger and animosity, as our architect friend said. So Francis Peabody wrote this on just before he died in 1926, I think was when it was, but published in JAMA in 1927. There wasn't a malpractice crisis when he wrote this, but he's really giving us the best advice to minimize malpractice risk. So it's by far the best advice. So I'll just give a patient study. This patient calls me patient family calls me every April. A woman calls me every April. It's the date of her husband's death. He died after all this, years after this. But I'm just going to tell you this is pretty typical. So we had a 61-year-old man in a high-speed motor vehicle crash. He had a normal abdominal CT scan. He had femur and tib-fib fractures. He went to the OR, has fracture repair. This was years ago, like 15 years ago. We transferred him to orthopedics post-op, and he had persistent abdominal pain. And his wife was at the bedside saying, there's something wrong. There's something wrong with this patient. Of course, she wasn't on our service, and we relegated him to the orthopedic service. And there, of course, look at the bones. And long story short, he sat there for more than 24 hours. Whenever I first saw him, he looked awful. He looked about the color of this podium. He had a fever to 102. His white count was 25,000. And his wife had been asking for a general surgery evaluation for more, and she was very sophisticated. She was asking specifically for a general surgery evaluation for more than 24 hours. And she was not a happy camper, let me tell you. She's about this tall, and she was mad. And he had an acute abdomen. And she looked at me, and she pointed her finger at me, and she said, you fix him, and you don't let anything happen to him, because if you do, I will be on your doorstep. I said, yes, ma'am. Yeah. I got the message. Message received. So we took him to the OR. We found the classic terminal iliomesenteric tear with a dead cecum and right colon. Of course, we did a right hemicolectomy and iliotransverse colostomy. We didn't do an ileostomy. We probably should have. We didn't. We were trying to avoid it. And post-op day 7, he was doing pretty well. Abdominal pain, fever, anastomotic leak. Then he had what I would call the full meal deal trauma ICU experience of sepsis, ARDS, open abdomen, tracheostomy, controlled ventral hernia, discharged to rehab 2 months later. Disaster by all accounts. He eventually left the hospital, and his wife took him to see Stewart Johnson, who she was a family friend with. She took him to see Stewart Johnson, who was gracious and kind to us because he didn't say negative things about us, and he said these things happen, and he portrayed us as the superheroes, And he basically fixed the hernia, put a large sheet of PTFE mesh. Then, of course, 2 years later, the mesh has a big fluid collection on it, around it. And she called me, and she had seen a bunch of people, and I said, well, it sounds like the mesh is infected. And we took that sheet of mesh out, and we were able to close the skin over it. And he had for the rest of his life, he had a manageable controlled ventral hernia. And he eventually died unrelated to this. She calls me every April and thanks me. Every April. Even though we messed everything up. And she knows it. I told her we messed everything up. Did not on purpose, but we had multiple things that we could have done differently. The point is, if we take good care of the patient, if we have a relationship with them, and if they know that we're trying to fix him as best we can, then you get a break. If they don't believe that, you don't get a break. What you get is persistent anger that's very difficult to manage. So phase 2 of this is what have been the effects of tort reform. I'm going to kind of move quickly through this. But what's taken for granted, I think taken for granted for most surgeons, is most surgeons believe tort reform is very, very needed and beneficial. it's one of the things on the American College of Surgeons surveys that people, that when you get those, it's when the college does those surveys, it's one of the top, it's in the top 5 every year, tort reform. It's on the agenda for the American College of Surgeons. But I want you to look at who these authors are. Studdard and Mello have written more about malpractice than anyone in the United States. And the third author is Atul Gawande, who is clearly the most prominent lay writer of surgeons. I mean, certainly in the top 2. And what are they saying about tort? They're basically saying that, tort reform, if successful, will have a limited effect, and really the main effort should be streamlining the processing of claims. So should actually be assisting getting those claims processed as quickly as we can. Well, this is a problem. So to answer this question, we looked again at our data, and we basically looked to compare the total number of lawsuits filed before, the total lawsuits filed, prevalence, incidence, and risk before and after tort reform. So from periods before and after tort reform. And for definitions, liability cost was awards to plaintiffs, legal cost was the money we paid for defending those lawsuits, and litigation cost was the total. So again, thanks to Dr. Page, we have 98,000 general surgery procedures. There were 28 lawsuits filed during that time period, about half and half. Half were settled, half closed in favor of the surgeon. And there were 3 in the post-tort reform period. 1 is not open anymore. It's settled in favor of the surgeon. So 3 suits in the post-tort reform period, equal periods of time. 3 in the post-tort reform period, all settled in favor of the surgeon. So when you look at the risk of that, remember we have a denominator for this, was in the pre-tort period there were 40 lawsuits per 100,000 procedures. In the post-tort reform there were 8 lawsuits per 100,000 procedures. So really almost a 5-fold decrease in the risk of lawsuit in the post-tort reform period. What about cost before and after tort reform? Well, just to be fair, I have a good friend of mine who's an attorney. She's a defense attorney, and she beat me up worse than the previous patient. I said when she saw this paper, she said, you know, this is gross exaggeration. $7 million versus $595,000 per year versus $515 per year. I know that's not right. Blah, blah. And it is correct. This is correct in the general surgery patients. This is correct data. But she's right that it exaggerates the effect of it. But clearly a big cost difference. So a better way to look at cost, instead of just looking at those general surgery cases, would be to look at all 10 divisions over that time period. So the problem with doing that analysis is we don't have denominators for all of those. For the surgical specialists, we didn't have Carrie Page's database, but still, it paints a pretty interesting picture. This is over equally divided time periods from 1976 to 2011, and you can see that over each period pre-tort reform, there is an increase in lawsuits filed from 1976 to 2004, and then a dramatic fall-off in 2004. And when one looks at the cost, this is adjusted for inflation-adjusted 2010 dollars. In the pre-tort reform period, 1998 to 2003, was about between $6 and $7 million. In the post-tort reform period, over all of those 10 departments, 10 divisions, was about $2 million. So for Rosemary, this is still a better estimate, but still significantly decreased. And similarly, probably many people don't know, but the UT system is a self-insured malpractice plan. And these are premiums for risk class 4. There's been a significant decline in malpractice premiums. And then this is the to take the lens back to the whole institution. This is total health science center liability cost from 2003 to 2011. You can see that it's just fallen off in the post-tort reform period. So in summary, tort reform in Texas decreased caseload and cost from our institution and our department. Almost a fivefold risk reduction in lawsuit risk, and probably if we were added on the next couple of years, assuming tort reform holds up, probably those numbers would probably be even more dramatic. So tort reform definitely decreased the risk of malpractice litigation, and to answer that question that really stuttered Mello and Gawande were, limiting economic incentives reduces caseload and cost. Limiting economic incentives reduces that. So we noticed, though, in the post-tort reform period that we hadn't really defended many Texas Medical Board complaints. We had not actually, it was not actually an issue even covered on the malpractice but we thought that there was an increase in Texas Medical Board complaints. And Loring Rue from Alabama poses a very good question for Texans. And he basically says, have you just really traded one evil for another? That the medical board actually may be worse. It's equally trying, expensive, humiliating, and maybe you don't have the same protections as you do in the tort system, which is a very good question. So we set out to try to answer that question, not from our data, but using publicly available data from the TMB. And we looked similar to the other thing. We looked before and after tort reform. And I'll just get right to this, that the number of complaints in the pre-tort reform period compared to after tort reform increased. It was significant. It significantly increased. So number of complaints to the board increased, but a relatively modest increase, but definitely increased. And I left out a slide that I usually have on this. Remember in 2003, the same legislature in Texas not only passed tort reform, they passed legislation that enhanced financial support for the board and gave them specific direction that they need to increase their vigilance and do more. That was legislatively driven. And there were more complaints before and after. If you look at so now you have a complaint, then the board has to open an investigation. So there were more investigations opened than there were actually greater than the increase in complaints. Investigations were open. And then when the board took action, a disciplinary action, that was even more disproportionate. So not only were there more complaints, but the board is now acting with increased fervor. Now, revocation of license were statistically increased in the post-tort reform period, so people losing their license was increased, but not quite as much. And also, I'll point out for both the previous slide and this slide, the frequency, we need to look at the scale. These are really low probability events. Disciplinary decisions per 1,000 physicians in the post-tort reform period is 8 per 1,000. In loss of license is less than 1 per 1,000. So a very small subset of physicians. But financial penalties definitely increased per 15,000 per physician compared to less than 5,000 in the pre-tort period. Again, this just sort of summarizes it. You have an increased number of, this is 1 here, so you have an increased number of complaints, but disciplinary actions significantly increased from the board. So, but to be fair, we need to do an apples, this is maybe not a fair comparison, but remember the data that we just talked about our own Department of Surgery's liability expense. So if you look, that was about $5 million over this same time period. So we spent $5 million in litigation costs. The entire state, not just our department, the entire Texas Medical Board penalties for the entire state were less than 5 million over an equal time period. So it's a retrospective review of prospective data, but probably the main limitation of this is that these changes were driven by the legislature. The Senate Bill 104 from that session really drove this process. So there's a modest increase in TMB complaints and a significant increase in penalties. So tort reform was accompanied by enhanced oversight from the board, and the significant reductions in lawsuits were accompanied by increased TMB penalties, again legislatively mandated. So putting all these together, tort reform significantly decreased the risk and cost of malpractice litigation, limiting economic incentives, reduced caseload and cost, and there was legislatively enhanced oversight and activity from the Texas Medical Board. So if I were to summarize and close, I would say that the legislative goals of 2003 were both accomplished. And when you consider both those changes together, costs significantly improved, there's more physician oversight, and there's the process replacing the tort system with the TMB system is perhaps more emotionally difficult for physicians, but it's clearly a more equitable and transparent process compared to the tort system. It probably doesn't do anything, though, for nuisance reporting. That probably is just as bad under the TMB process. So what should our goals be moving to the future? Well, I think the number one goal that we should have is to make certain the benefits of tort reform clearly have been beneficial for Texas surgeons, but we need to make certain the benefits of tort reform actually get passed along to our patients in the form of access, cost, and quality. Those are the things we can do to help the patients. So the second thing is, which is much easier if we do the first, because there's a tremendous, well-funded opposition to tort reform. But the second thing is we need to preserve comprehensive tort reform in Texas. And the third thing, which oftentimes we don't think about because of this increase in TMB reporting, but we need to make certain the Texas Medical Board functions well to protect patients, providing appropriate oversight of the practice of medicine while being fair to those people who are competent. I'm happy to answer any questions or have a discussion. Thank you. Dr. Schweizer.
Very nice overview and show a real grasp for the important issues. I guess what bears emphasis in terms of how we relate to patients, and you said it several times, but I think it's still really important because it's so difficult, and that's being honest when you have a complication. You just can't overemphasize that. It is difficult to walk up to the family and say, we screwed up, but you need to, because if you don't, then it takes on the aura of cover-up, and you never get past that. So you've got to be honest and upfront right away. You can't wait to do it. You've got to do it if it's in the operating room that you've created a problem. You've got to talk to them immediately post-op. You can't wait till the next day. So the key issue is be honest and make it timely. That will serve you well, and it should be instinctive, but it's difficult to do.
The question was, do you apologize?
I have, yeah. I mean,
well, so you know there's data on that too.
It depends on what the complication is. I mean, you have to acknowledge that there has been a problem, and I personally do apologize, but you do it in a proper way.
What is that proper way?
Be yourself.
Be yourself. Be honest.
Everybody's going to do it a little bit differently. I think that the emphasis, though, is that you acknowledge that a problem has occurred, you put it in its proper setting, and be yourself in dealing with the patient.
So I would add, the only thing I would add to that is I think you should, I'll just say, I think you should definitely apologize if an apology is warranted. You should apologize, and you should always express empathy and concern, and it should be really clear that you're sorry for what's happened, even if it was not something that you personally caused. There's data that shows that approach leads to a lot less litigation.
Well, and the reason I bring it up isn't because I'm particularly good at it. but the reason I bring it up is because it's difficult to admit mistakes or admit problems. And for the young folks starting out, it's really difficult. I've been there. I'm not sure I've always acknowledged it in my infancy. I still get the shivers about the patient, the mentally retarded patient who we've left a sponge in when we were doing something simple like a pacemaker. And I don't think I handled that right. But I learned from it, and so I'm trying to emphasize now that so somebody else doesn't have to learn the way I did.
Also sleep better at night.
I agree with that, Schlesinger. And also to keep a nice rapport between you, the patient, and the family. Even though if you made a mistake, if they know you are devoted, they will not sue you. And this has happened throughout the history. The other thing I'd like to ask you, is there any arbitration board here in Texas? Arbitration board?
Some people have talked about using the local medical societies as somewhat of an arbitration mediation between as a substitute for the tort system, but I think there is some rudiment of it in Tarrant County, but I think in most places in Texas there is not.
Because my experience in Maine, we have an arbitration board, and the case is presented to the committee, which is made of surgeons, lawyers, etc. If they turn the case down, there's no need to pursue. Even if you settle the case, the insurance knows they're not going to win, so they pay. There's less money involved. There's less lawyer involved. Now, the patient can still sue, but his chance of winning is almost zero. And it has been worked very, very nicely in our state.
So, and if I could follow up on both yours and Dr. Schwesinger's comment, there is another thing, too, which I think is definitely should be done. And I will say it's one of the things that's harder to be done post-tort reform than pre-tort reform. But when there's been an injury and when it's clear, when we know the facts, it's clear, we didn't do it on purpose. I always give the example to the patient's family. A lot of them have raised children and they know what raising children is like. I don't think 99% of parents try their best to do the right thing for their children. But sometimes it doesn't work. And sometimes when they look back, they would do it differently. And sometimes things get really messed up. But it's not like, so most can relate to that. But the one thing I would say, it's harder to do in the post-tort reform period. But when something is really bad and there's been a significant injury, I personally think it's much better to prospectively settle without a lawsuit. To basically just say, we're going to put you in touch with the risk management folks. These are the facts. And to encourage the risk management people to prospectively settle, because there's some things where there really is a horrible financial medical care burden after that. Really makes a difference with respect to many people in that setting don't move forward in the tort system because they feel like people are being honest with them. That's harder to do in the post-tort world where there's not the lottery system. It's harder to get risk management people more engaged in that.
Ronnie, one other point besides what Dr. Schlesinger had to say is that the communication problem really comes to a head, and you have to analyze what you do yourself when we get patients who are then referred to the tertiary center because of a complication. And we have to be very supportive of the patient, but like you said, not actually blame the other physician or surgeon. But the majority of the patients there's a huge communication breakdown. Sometimes the surgeon walks right out of the operating room and said, I cut your husband's bile duct. But I would guess out of the patients that we see, there isn't a really good explanation. It's kind of a little black magic and mumbo jumbo and not quite straightforward. And I think it really emphasizes the communication problem. The other question I have is, you've presented this and written about our own experience here. Do you think our self-insured system has affected the results? One of the lawyers in 1972 came up with the self-insurance program. And as you were talking, it would be great to look at the Texas Medical Liability Trust, which I think insures 25% of the physicians in Texas. And because our Texas Medical Trust, I mean, really fights vigorously and not to give awards.
Well, so TMLT, I think the TMLT data, I've not personally seen it, but I think the TMLT data is very similar to this. But it should be emphasized that we actually have, for the people who are in the UT system, have additional, this was comprehensive tort reform, not just limiting awards. There's all sorts of other elements in the tort reform bill, rules, and part of it is enhanced protection of state employees and governmental employees as well. So there is a difference, and we actually have added protection. But here's what I think happened in the state. This is a gross oversimplification. But what I think was, just like there's an emotional component for doctors, there's also a bit of an emotional component from attorneys. You have to think about it. $250,000 is nothing. It's not nothing, and you could actually get $250,000 from the doctor, from the hospital, and from someone else. There's yes, para-hospital personnel. So it's not nothing, but there's an emotional component. I think the plaintiffs' attorneys, a lot of them just looked at it and said, we can move on to a different line of business that's more profitable for us than this. Yes, sir. Sorry.
Well, I certainly agree that, we should focus on what we have control over, and that's certainly our relationships with the family and the patients.
Yes, sir.
But looking back at the litigation when it was passed here and the available data in 2003 in that legislature, one of the things that I noticed was that if you look at the 17 other states that had passed tort reform and placed caps in place, in virtually no case did the premiums that the physicians had to pay go down. The settlements may have gone down, the number of cases filed may have gone down, but the premiums paid to the insurance company didn't go down. And I know shortly after that, because TMLT had spent so much time promoting tort reform, that they pretty much cornered themselves into having to lower their premiums. They didn't have any choice about it. Mm-hmm. But I'm curious what the data has shown since then. We have two other major carriers in this state that are licensed to sell, professional liability here. What's gone down there? Because in the past, if you did an analysis of the data, the thing that was escalating the premiums was not only the medical cost of care, for the actual disability, and so capping, pain and suffering didn't really affect that. But the big thing that was driving the cost rise here was out-of-court settlements by the insurance companies. Mm-hmm. They didn't want to pay for the litigation cost when they had as you pointed out, they had a 75 to 80% chance of winning the case for the physician. So they made a settlement, and the settlement was nearly always, if you looked at it nationally and you looked at the cases and the jury settlements and things like that, it was always larger. The settlement, the out-of-court settlement, was always larger than the jury awards, average jury awards were. So, I think the insurance companies, we don't have control over that. We don't have control over the judges and the lawyers and the courts, and we really don't have that much control over TMB. But the insurance companies had a lot to do with driving the premium costs here, and tort reform doesn't seem to have any impact on them. So, being self-insured seems to be an awfully good idea.
Well, clearly, I don't know. I'm really, I'm not an expert, but that won't keep me from commenting anyway. But I think it's definitely a good idea for the UT system. It's been one of the things that, because that is money that not only do rates go down, but when there's not awards given, then there's rebates to the people who are funding it, which are the providers. So it's clearly beneficial, and also it's also been beneficial in the post-tort reform period, because those rebates they've been able to specify, they didn't just go to the bottom line. Those rebates came back and were used for patient safety programs, funneled in. So I personally think having a self-paid plan is great. But I agree with you about but premiums have fallen, and they probably have fallen for, I don't want to be too jaded, but probably fallen for the reasons exactly what you said. But if you talk to folks in the Valley, their premiums have definitely fallen. But it's probably because everyone was so behind it and was promoted by everyone, including the carriers, that I think it would have been really bad if rates didn't fall. I think you're exactly right. Other questions?
You gave a lot of tremendous advice. Because so much of this is about the relationship with the patient, I think it's important to realize that when you first meet a patient, you need to listen to the patient. And if the patient's not comfortable with you, you ought to offer a second opinion. The last thing you want to do from the very beginning is get off on a relationship that isn't going to work out. And you have to accept not every patient's going to be comfortable with you.
Absolutely. Good. Great advice. Okay. Dr.
Just real on the other end of that is be accepting of patients from others. Because that's, God, this guy's a real ass, and I'm going to send him to you. So just, but again, on that same end, if one of your partners has somebody that's not comfortable with them, again, like you said, don't disparage them, but be willing to accept them.
Okay. Dr. Dent, State of the Residency.